Hi, my name is Ashvin
Yeah,
Agarwal.
yeah,
I'm
done.
here to talk to you about what's my choice of IOL placement when I don't have capsular support. So let's take a very, very complex scenario and let's see what we can do about it. I do have financial interest with ELISA, but none of it pertains to my talk today. Here's a case of dropped intraocular lens, but just not any dropped intraocular lens. It's a dropped intraocular lens with a full capsule and an endocapsular ring. So what I'm trying to do here is, because I have no bag support, I have to first make my glued intraocular lens flaps. I'm making my trocar entry so that I have infusion inside at all times. And then I'm making my sclerotomies 0.75 to a millimeter behind the limbus. Once I've done with these two on both the sides, I'm basically making my corneal entry. And mind you, sometimes these sclerotomies can bleed. So just wait for a bit and be careful when you do this. Once you're done with this, you're basically doing an anterior vitrectomy to ensure that there is no snagging or yanking on any vitreous that is happening. Post that, I'm placing my 3-port pars plana vitrectomy, completing a complete core vitrectomy of sorts. And once I'm pretty much thoroughly completed my vitrectomy, in this case, I'm now ensuring that there is no vitreous around my IOL bag CTR complex. I'm taking my ECAL probe, that is the extrusion cannula probe, and by use of the extrusion cannula, pressing my foot pedal, basically causing a vacuum on that optic, I basically levitating that up into the anterior chamber. And now once this is into the anterior chamber, I have now a CTR, which I'm trying to find the edge of. Once I find the end of that CTR, I'm trying to now expose it from the bag first. Once I have exposed it from the bag, I'm also trying to explant it. But I know if I yank on this too much from here, it might snap and I might have a CTR segment on my retina. So now I need to be a little bit more careful and I need to be a little more judicious in my approach. So what I'm doing here is ensuring that I twist or supinate my left hand so that my right hand actually brings the edge of that CTR segment out, and I bring it in a circumferential manner outside the eye. Once my CTR is out, I know my bag came with that CTR segment. I'm not so worried about the bag as much as the intraocular lens in this case now, because the intraocular lens is now admixed around with a little bit of vitreous here and there. Ensuring that there is no more vitreous around that intraocular lens, I bring this intraocular lens into the anterior chamber, and that's the most important step here. Bringing this intraocular lens into the anterior chamber and leaving it here for some time. And why? We'll come to that very soon. Once this intraocular lens is in place, I basically push it towards one side and now place my do an anterior vitrectomy to ensure that there is no anterior vitreous in the anterior chamber. Once there is no vitreous here, I'm able to now remove my uh, I'm able to push this optic of this intraocular lens aside and place my glued intraocular lens by grabbing and externalizing one haptic first under the intraocular lens that is already there. Once this is done, I now have a safety net or a scaffold of sorts that basically helps me prevent this IOL from dropping inside. And now I grab the second or the trailing haptic, externalize that. Now I have both my haptics externalized safe, but is it sturdy? Is it stable? Not yet. So I'm doing my Gabor Chariot's tunnel here with the tunnels in place and the haptics tucked into those Gabor Chariot's tunnel. I really have a lot of freedom to do what I need to do to actually ensure that I can remove this old lens from the eye. Because mind you, you cannot glue a single piece foldable lens like this. So what I'm doing is using a pair of scissors, intracameral micro scissors. I'm able to cut this into two halves, and once these two halves are there, I'm able to explant both the halves of the intraocular lens, thereby ensuring that I do not need to extend my corneal incision, causing a lot of trauma, astigmatism, and whatnot. This has probably been a revolutionary change in the way that I handled IOL exchanges whether it be with or without glued intraocular lenses. Once that is done, I'm doing a air bubble test to check whether there's any optic capture. Since there was no optic capture, I removed all my trocars. I have placed, I've done my stromal hydration, and I'm doing some glue under the flaps to ensure that the flaps are sealed in and the haptics are buried with the flaps. This pretty much is the end of this case, and I wanted to show this because this probably is the least traumatic way of doing an IOL exchange with a glued intraocular lens, or some sort of mastering of this glued intraocular lens in different complex scenarios. Thank you very much.